Are you ready to start? Okay. The reason why we are doing this 15 minutes, because of this beautiful lady. My presentation is on how to treat a complex case, but it's timely to talk about Thomas zero bone loss theory today, because every day in the clinic we are facing unclarity from you guys about this theory. So we want to solve it. So this 15 minutes, focus with me. We want to resolve Thomas zero bone loss theory, and hopefully more people will come. Okay. So what do we know about implants when they are platform switch, when they are below the bone level? Is we have, imagine the bone is slightly above the implant. The inflammation, which normally should, if this was not platform switch, the inflammation should be here. But because it's platform switch, the inflammation is here. So because of that, there is no irritation on the bone, because every time you eat and this moves a little bit, this moves and the bacteria goes in and comes out, goes in and comes out. So the inflammation is here. That's the first. So the first theory is always use platform switch. First, you can leave it here and remove this too. This is yours? Thank you. Alright, the second theory. Place the implant below the bone level. That's the second part of the theory. Always. No, that's later. We talk about minimum maximum. But always place the implant below the bone level. For now, for the sake of argument, let's say 1 millimeter. Okay? But this is not fixed. But it should be below the bone level. That is the second element of the Thomas zero bone loss theory. The third element. You with me? Yeah. From the time the implant platform is placed, there will be a connective tissue which is around 1.5 millimeter will form above the implant. This 1.5 millimeter should not be disturbed. How can you disturb it? By making your crown like this, or making it glazed, or making it unclean, or making it with calculus, whatever. So the first 1.5 millimeter, this is connective tissue. This connective tissue should not be disturbed. You should not invade, you should not make it convex. If you can make it concave, even better. You should try to be straight, not divergent. And you should never, ever glaze. This 1.5 millimeter of the area above the implant should be treated different than the entire crown. Now you might say, can I put it in titanium or can I put it, he said glazed. Glazed, you cannot glaze titanium. Can I put it in zirconia or I can put it in titanium? The answer is what she said. What was her question? Depends how deep you place the implant. That decides if this area is titanium or it is zirconia. Doesn't matter. If it's zirconia, it should be
Not glazed.
And if it's titanium, it should be
Polished.
polished but not divergent.
Yes, not
It should be straight. Or concave, even better. Right? So we are okay with this far? Okay. Now we come to the shape of this bone. The shape of this bone, if it is cortical and it is touching this implant tightly, and here is cancellous, and when you are putting the implant and you have 45, 50, you're very happy, and this is very soft bone with your Hounsfield unit, you check, this is very soft, but you have 45, you have 55, 65. The reason you have big number of torque is because of the cortical. He says don't do this. He says don't allow the cortical bone to be under
pressure.
stress or pressure, because to every action there is a reaction. If this guy is soft, if this guy is water, if he is water, okay, and I do this, what happens? Nothing. But if he is a brick wall made of steel, if I press this, he will not move. He will react to my pressure, okay? And if I hit him, I'll break my hand. Correct or not? So, Thomas says, check this bone with your Hounsfield unit when you are putting. If this is cortical, make sure you make it divergent, this part, the part which is above the bone, make sure it's away. So when you are putting your abutment, you are putting your eye physio, you are putting your crown, whatever you are putting, this bone should not be under pressure. So always the neck of the implant, the neck of the bone should be either cancellous, and it should not be touching any of your abutment, crown, zirconia, whatever, even the healing. You okay? When there is no stress on this, what he says will happen?
It will not give any stress back.
Yeah, but what is the...
Inflammation.
For resorption.
I'm looking for something.
Stress will not be on this bone. It will be.
I'm not interested in the bone.
It will not disturb the connective tissue.
This 1.5 millimeter, it will stay where it is. The point is, you want this 1.5 millimeter not to be disturbed. Once it is disturbed, it has a sensor. It will tell the osteoclast to come because I'm disturbed. I'm not happy here. And I'm more happy where there is no stress. So it will recede and you will see the gum receded. 1 millimeter, 2 millimeter, many people accept. 2 millimeter is okay. Many of you accept 1 or 2 millimeter of recession after 5 years. With Thomas theory, we don't accept. So the key is not to disturb the connective tissue. All the possible theories we are talking here is this 1.5 millimeter should stay in this location where we started the surgery. So all the things we are saying, all the elements, is for this 1.5 not to be disturbed. If it's not disturbed, there is no remodeling. Now you might say remodeling is a good thing. What do you want? Yeah. I think it's there. They're there. So remodeling is a physiologic thing. Okay? Now remodeling will happen because of the stress and the strain from the other parts of the body. If what you give in and you take out is equal, that remodeling is okay for us here. But if it's causing any stress and the remodeling means new attachment lower than what it was, and the whole world accepts 1-2 millimeter bone loss after thing, we are now not accepting that 1 millimeter, 2 millimeter. We are not accepting anymore. We don't want that. So, all of the things I'm going to tell you today is to keep this area undisturbed. Now, can we go deeper? Yes, we can go deeper, but there is rules. Can we go above? Not allowed. Why? Because one of the things that disturbs the 1.5 millimeter is the 5 millimeter rule. What is a 5 millimeter rule? If this is the line of the free gingiva, for this 1.5 not to be disturbed, okay, the implant should be placed not less than 5 millimeter below this area. So that's another element in the theory. Not to disturb the 1.5, you need 5 as a cushion. So, I think I mentioned all the elements. Let's repeat them again.
There's one question. The 5 mm rule, does it apply to both type of tissues, the thin and thick, or it should be different?
Okay, now we will come to that definitely. It's a good question.
Can I ask my question?
Yes, please.
Another that when we are making a recovery, usually we make the gum more thick from buccal side. Sometimes already we have 2 millimeter of thickness of connective tissue and soft tissue, but we add more when we make the recovery, especially the technique where we, what you call it, to put the gingiva roll technique. So it become more four, for example, or 3. This will affect that 2 millimeter.
The lingual becomes 3 or the buccal becomes
No, the
4?
buccal. We're talking about the buccal.
Becomes 3?
When we make the roll,
Becomes, you mean more
the
than
thickness,
5?
yes, the thickness of soft tissue.
Yeah.
It will become more
Yes.
than 2 millimeter.
Yes.
So it will go back to 2 millimeter, it will stay more than 2 millimeter.
Eventually, in say 15 years, it might go back. But in the beginning, it will always remain. For a few years, it will be thicker.
This,
And it will have more blood supply than the
thinner.
thinner gingiva.
I measured my soft tissue on top of the bone
Height or buccal?
height. The height. It was 2 millimeter
From bone level?
Yeah.
Or from implant level?
from bone level. Before I placed the implant, it was 2 millimeter. I measured it with a probe after anesthesia. Does that mean I need to place my implant 2 millimeter below the bone?
3.
3.
If you have only 2 millimeter,
Yeah, only.
which is very rare, normally it's 3, according to all the articles we see. Average is 3 and more than 3. So if you really have 2,
Yeah.
then you place the implant 5 millimeter from the gingival level.
Yeah.
That means 3 millimeter below the
Bone.
bone level.
Okay.
So is this going to affect the abutment later on if we place a subcrystal like
We mentioned, you were there in the beginning?
No.
I'll repeat it when we come again. Yes, it will affect, but it's already in the plan. Okay, so what all these articles are saying is, there is an average for the whole world. So it's not something you have to be surprised. We know the approximate amount of the biologic width, which is fixed. The connective tissue is around 1, and when we leave 1.5, we are sure we are not disturbing the connective tissue. Okay? So this is fixed. We don't have to keep changing it for thick phenotype, thin phenotype. The connective tissue is fixed. That's why we need to leave this connective tissue 1.5 undisturbed. Alright, let us start from the beginning, the same theory. Alright, so imagine we did place the implant slightly below the bone level. We maintained the first 1.5 millimeter straight or concave, even better if we can make it concave. So the connective tissue is not disturbed. From here, if there is zirconia, it should be glazed because you don't want calculus to stay there, or super polish that the calculus cannot stick there. So if it's not polished, you have to see this area should be extra polished, because this is where the calculus starts attaching. For example, you do porcelain fused to metal, cemented. This margin generally, the lab might not be able, because the metal will heat the ceramic on top in the furnace. Sometimes, if they are not careful, the ceramic boils. You don't see it, but in the microscope you see it. Why it boils? Because they don't give the entire cycle. They put it on a quick cycle. So the temperature, instead of raising 4 hours and going 4 hours, it goes 10 minutes, 10 minutes. So it reaches the 1000 degree, and then the ceramic starts boiling. When it boils, it makes air bubbles and rough surface. You don't see it with your eyes. The lab will polish it with the polishing, and you see it shiny, but actually it has pores because of the boiling of the ceramic. So wherever you have ceramic on top of your, whether it's zirconia, whether it's metal, whether it's, what is the other one? Ichor? Not. There is another stackable, not Emax, the other one with the core, that they cast the core. Anyway, what? Huh? No, PEEK is plastic. So my point is, if the ceramic in this area is not very smooth, calculus can stay. I have a case, full mouth, 12 and 12 teeth. He did the framework porcelain fused to metal with me in 2004, 2005. That time, porcelain fused to metal was the strongest thing we could do for full mouth. He aged and the gum started receding and his dexterity reduced. After 20 years, I changed, it was full of calculus and he was not brushing. His wife told me, this patient, my husband, doesn't brush, by the way. He just rinses with water. He doesn't want to brush. He's old and he's not interested. Okay, I saw there was calculus, we cleaned it. Again, in 1 month there was calculus. The gum has receded. So there is room for the food to go and calculus to form. So what I did, I changed the porcelain fused to metal to zirconia bridge. There was no calculus. So that means if the lab does a good polishing with zirconia and a good polishing with porcelain fused to metal, you can have less calculus with zirconia. So try to keep that in mind for this kind of restorations. When you are very much concerned about the bone loss, you try to go to zirconia family, not to porcelain fused to metal family. It does make a difference in the calculus collection. So we are okay with 1.5. Whatever is here, generally 1, is going to be glazed, and it will start what? What is this called? Yes, not emergency, emergence. Many of you in the clinic, emergency profile. No, it's not an emergency. It's emergence, means coming out. It's not an emergency. It's not an emergency. Emergency profile? People who think it's an emergency, please note, it's not an emergency. It's an emergence, means coming out. Okay? Why it has to be here, not here? Because the connective tissue. Why here, not here? Because there is no time. There is only 1 millimeter. You have to start. Because this part has to be the diameter of the crown. And if it is coming straight and then square, again that will be the epithelium will be disturbed, this part. This is epithelium, this is connective tissue. This part you can what? No push. You can push, no problem. No problem. You can push the epithelium. Now the question is, his question is important. What was his question? Huh? Thick or thick? So if it is thick, you can push more. If it's thin, you can push less. So this part is not related to thick and thin. It's fixed number. Don't push. Don't disturb. This part, you don't have a choice. Here, yes, the thicker. Now, when Dr. Ahmed is saying he's rolling technique and he's making this thicker and all that, why he's doing all that? For this part. Even this is affected, but this part can be nicely pushed and you can have a better emergency. Okay? So this part can be pushed, okay, to make the crown look like a crown, and a nice transition from such a narrow to such a wide. This is the only time the lab has to actually make it look nice. So you need this emergence profile to be practically, the floss doesn't go down, the food doesn't go, all this comes here, not here, because this will be almost attached to this. The connective tissue, the hemosomal connective hemodesmosomal attachment, hemidesmosomal attachments will adhere to zirconia if it's undisturbed. And when you put your probe, hopefully, you stop here, not here. It's very easy to go from here to here, because how many of you know about the 4 forces of metal to ceramic contact? The 4 forces. No, not that kind of force. How the metal and ceramic are bonded. Give me 4 bonding forces. Mechanical, they make sandblasting. How is the chemical? No. Oh, you're touching that. Finish your chemical. When you heat the metal, there is an oxide layer, okay, on the surface of the metal. That is the strong 100 megapascal is the strength of that bonding to ceramic. The second one is the mechanical, which is around 30 megapascal. The third is the compression. When the metal expands, when you heat it, it expands, right? When you heat the ceramic, also expands. Which one expands more? Metal. So there is a difference between this expansion and this expansion. So when they shrink, what happens? Attachment between any two objects when they contact. For example, you etch a tooth and you put a drop of bonding. Okay? This liquid will quickly go inside. This is van der Waal. The first touch, you take a balloon, you rub it against your hair, it stays at the wall. It's not strong enough to hold the balloon. Slowly the balloon will come down, but it stays in the wall. What happened? Because of the van der Waal. Wait. If you go to that, van der Waal is 3, then I will spend half an hour. Let's not go electronic. It is electronic, but my point is van der Waal is 1 megapascal. But it is the shake hand of any bonding. The first two, they hold each other, is van der Waal. But it's weak. But it's the first thing. The chemical and all that takes time. Van der Waal is the first handshake. They call it the handshake of two objects meeting. Right? It's 1 megapascal. Even less slightly. Now, this hemidesmal attachment, the strength is the same as van der Waal. Van der Waal actually. W and then V. Yeah? So this attachment is not more than 1 megapascal. So when you take your probe and you are going to check the pocket for bleeding, why you check for bleeding? For perimucositis, because you don't want to have bleeding. If you have to do something, right? So when you are checking and you cross this area, because your hand is heavy, you don't pay attention to the weight of your hand, this is around 1 megapascal pressure, you can actually penetrate. It's very weak, but it's there. The same as balloon with the wall. It's there, but it's weak. Don't disturb this part. Because once you disturb, it might come back, it might not come back. You cannot guarantee that this connective tissue hemidesmosome, why you cannot guarantee? Because
of infection?
No. Why? No. Before calculus. The first sentence I said, once you disturb these people, this epithelium will travel. The fastest cells in your body is the epithelium.
This epithelium will grow faster.
Yes, finished. By the time the connective tissue wants to shake hand, already the epithelium, they move 1 millimeter a day. This will move, it needs days to come and make bonding. Yeah? So that's why you should be careful with this 1.5 millimeter. It's very weak and very serious, very important, very valuable for the remodeling not to happen. You don't want remodeling, too much remodeling here.
So I have two questions, doctor. One is about the polished versus the glazed surfaces, because most recent studies are showing that polished are better than glazed in terms of bacterial adhesion. And the second thing is about the ionic bonding between the metal and ceramic, the negative and positively charged surfaces or materials. Is this one of the bonding that you were talking
That's
about?
the van der Waal. That's the weakest. It's 1 megapascal. That's second answer.
So van der Waal, does it have anything to do with the negative and positive
Yes,
charges?
of course. Van der Waal is divided into 3 different ways it works. One of them, it pushes the, I don't want to go to that because it's very far from this topic. If you Google van der Waal, there are 3 types. One of them is the negative and positive. But it's very weak, but it's the first connection. The first bond. If you want to not forget this, your relationship with your wife has 4 forces: chemical, mechanical, compression, and van der Waals. Think about it, it's relevant. If you go deep into it, think about it, all these 4 elements are there. There is the weak one, there is the compression one, there is the chemical one, there is the mechanical one, all of them are there. So it's not very difficult for us to understand different forces in one relationship. Now, since we are talking about gingiva, that's why I had to mention that this is very weak. So this was the simplest metaphor I could bring to make you remember every time you want to check for perimucositis, don't go. Now, regarding glazing and polishing, if you can get such a polish that when the patient comes after 1 year, you don't see any calculus there, that means your lab is very excellent in polish, fine. Our worry is, in Thomas's theory, he says glazed surface does not, for some reason, it does not accept calculus. It's so smooth that the calculus cannot attach to it. Whereas with polished, still it doesn't have that repellent effect of glaze, that extra glassy. You know, it's a surface. Glaze is not polished. Glaze is additional glassy surface to make it slippery. You understand? So if you can make it slippery for the sake of the calculus not to stick, I don't know. Actually, I think it's safer to glaze than to polish, and maybe it's not as smooth as glazed.
So you agree that the polish is better in case it's not perfect?
If it's done perfectly and you don't see calculus there later, after 1 year. If you see, glaze should have been done, because glaze is a surface. Polish is not a surface. Polish is a smooth, existing, porous surface. Glaze is a glassy surface, additional layer with no pores in it, if it's done right. Also, glaze can be not done in a smooth way, and then it's not okay. Yes, my dear. Give him the microphone.
Only I need to ask about the histological and anatomic, this one, about junctional epithelium, the relation between the junctional epithelium and the tooth. In this picture, junctional epithelium, no relation with the enamel, the relation with cementum. Can I come here?
This is the connective tissue which is attached
No,
to the...
no. Can I come here?
Yes, please.
Sorry. This area, junctional epithelium. The relation between the cementum, not enamel, connect here, must be, this must be here. Here cementum. Correct?
Not the connective tissue.
Yes. This enamel, how can fiber shut?
Yes.
Not
I
with
agree.
cementum.
I agree.
Go.
Probably it was just not very accurate. The point we're trying to show here in relation to the eggplant, there is a circular epithelium, then there is a junctional epithelium, and there is connective tissue. So here we have the connective tissue, which is very sacred. Why? Because we don't have Sharpie's fibers going inside the cementum, and these are going around it. So these hemidesmosomal attachments are within few megapascals, 1, 2, versus this one, it's very strongly attached to the tooth. So you should understand the difference between this and the difference between this. And this is very vulnerable to your probing. This was the reason for the photograph. But thank you. All right? So, we know the 1.5, straight, not divergent. We know the epithelium can be pushed and it can be glazed. Okay? And the biologic width in tooth is just 3. In implant, which is around 4, and we are calculating the 1 millimeter of the cervical epithelium. So from here to here, okay, we do want you to place a 5 millimeter zone of area to be safe. Now 4 millimeter, if you have a very thick gingiva, it's okay, but somehow the 5 millimeter is the safest. Sometimes if you want to place 5 millimeter, you have to place the implant very deep, and you are not very comfortable in that deep. 4 can be the minimum. So between 4 and 5 is somewhere that you have to decide where to place the implant based on the gingival margin. Now, the reason why I'm putting this is you don't relate implants to when you're making a crown. In a crown, you have a 3 millimeter biologic width that you should not disturb. You can disturb the first 0.5 millimeter, up to 1 maximum. That 2 millimeter you cannot disturb because you have a 3 millimeter of biologic width. In implant, you have another millimeter or more to disturb intentionally. So break that 3 millimeter biologic width for if you think tooth and implant is the same, that is 3, this should be 3. So always calculate 3 millimeter from the CEJ. You remember 3 millimeter from the CEJ? Today, 2025, we come to conclusion that information is not correct. It's not enough. 3 millimeter for implant to have emergence profile and not to disturb the connective tissue, according to Thomas, is not enough. 4 is the minimum, 5 is even better.
Okay, one question. If we have uneven tissue,
The lowest.
buccal and lingual.
Buccal, the lowest.
Okay, the lowest buccal.
Buccal. If you have a curvature, you have a high papilla and a cervical area, don't calculate from the papilla. Calculate from the lowest cervical area. Now, if you have lingual slightly lower, you will have disturbance of the 1.5, but then you don't want to go deeper buccally, because again you will have disturbance.
So can
So
we?
you rather have buccal stability and lingual remodeling versus the other way. So buccal, since it's visible, you want to have buccal stability of the 1.5 millimeter of connective tissue without disturbing. That's why you're applying all these rules. Okay, so the glazed zirconia, the unglazed, will be the 1.5. Now, if your abutment is say 0.5 millimeter, you with me? If your abutment height is 0.5 millimeter and your implant is 0.5 millimeter deep, fine. So the deeper you go, the abutment cuff height becomes an important issue for selection. What part of the abutment? Cuff height. So who decides the cuff height for abutment selection?
Doctor.
Of course, doctor, but who? The depth of the implant. The depth of the implant takes care of the cuff height. Once you reach to the bone level, then the zirconia. Now, if you buy 0.5 millimeter for all your cuff height, for all your implants, and you allow the zirconia to to decide, then you are disturbing the 1.5. That's my point. That's why we are keep every day, every week we are putting in the group about this. We're putting photos every day, try to make you understand the formula for the cuff height is related to the depth of the implant. So you want to be approximately 0.5 millimeter above the bone level with your selection of the cuff height, depends on the depth. Now you say, why should I put it so deep? Because you want to be 4 millimeter below the gum, maximum 5. Between 4 and 5, not 3. 3 doesn't work for implants. We used to think, because Gargiulo said 3, so we used to go 3 and we have disasters. Everybody accepts 1 millimeter of bone loss first year. Why 1 millimeter of bone loss? Because the body wants to go to 4. So give him 4 from the beginning. Why you want the bone remodeling to go to 4? So from the beginning, put the implant deeper. If you have a wide ridge and a posterior molar, you can even go to 5. So you can get nicely your emergence profile without disturbing the 1.5, and all this gum will stay. So as you go posteriorly, you can have little more freedom to go little more deeper. Not the reverse. We used to teach in the posterior, even if you are 2 millimeter below the CEJ is enough. Actually, it's the reverse. You should go deeper to get the beautiful emergence profile and keep this gum at the day of surgery. So the provisionalization of the gum at the day of surgery now is more important than before. Before, put the implant, cover screw, close it. Then you collapse all the gum, and then at the time of uncovery you have a small gum and a big tooth and a depression on the buccal, always. We're trying to avoid this by telling you all these details. So for example, we have the eye physio, we are trying to create temporary abutments if you're using other systems to keep the shape of the gum as open as possible at the day of surgery. Alright, so let us...
So the cuff height, if the implant 1 millimeter below the bone level, the cuff height will be 1.5.
Yes. Okay. Depends. Can you maintain the 1.5 untouched? Because this is the first. You have to keep sure. Can you maintain? For example, this implant is slightly above the bone. Then do I have 1.5? No. See? So that's why the 1.5 undisturbed is the first priority in your abutment selection. Everything else has to work around the 1.5 undisturbed connective tissue.
How to locate this 1.5?
Exactly. Above the implant. So if the implant is placed above the bone, from here it starts, the 1.5. Because this is connective tissue.
This is the undisturbance.
Yes, from here till 1.5 you should not disturb. So the more you make your abutment buckle in this 1.5, the more you are creating remodeling. The more straight you are, or concave even, the less remodeling.
So the cuff is included in this area, undisturbed.
Yes. Yes, the cuff height should invite this connective tissue to a place where it will not be disturbed. Alright, now.
So if
We measured that the soft tissue is like, let's say, 2 millimeters. So we have to go 2 millimeters deep below the bone.
Yes.
So the cuff height will be 2.5.
The cuff height will be 2.5 to the bone level,
Yes.
and then 1.5 millimeter of that will be unglazed,
Polished.
and you have only
unglazed.
0.5 millimeter left for the epithelium.
Okay.
Doctor, can you go back, please?
This is the
To
same.
the previous one? No, to the previous one. Can you explain on this one? This is the whole 1.5 millimeter is the cuff height.
No,
The metal and the ceramic, or both of them, or one
both
of them?
of them. From the bone, the 1.5 starts. From the bone, the 1.5 starts.
And this is the cuff height.
This is, no, this is the connective
I
tissue.
understand, but let's go to the cuff height.
The
How
cuff
much
height
the cuff height should be part of this connective tissue?
doesn't matter. Whatever it is, it should be straight. It should not disturb. So if your implant is here, then your implant is here, of course the cuff height will change. So the cuff height should be helping you to decide that 1.5 millimeter of connective tissue above the bone does not get disturbed. My issue with this formula, why I'm so sensitive, is all your implants is receiving a 0.5 millimeter cuff height. So if the implant is here or here or here or here, the zirconia will start after 0.5 millimeter.
So it will diverge.
Either diverge or even not diverge. The zirconia should not start here in bone, because you choose a 0.5 millimeter cuff height, no matter. So I'm trying to open your eyes to this 1.5 from the bone. If you put the implant wherever, you calculate from the bone till 1.5 millimeter should be undisturbed, straight, unglazed. Now, Arabic is, what terminology I should use? You find your cuff height. It's your talent and your ruler and your, because every patient will have a different depth. And she also mentioned the issue. In her case, and he also said, it's only 2 millimeter of gum for this patient. So you have to be smart. 2 millimeter of gum means 1.5 I should be straight. So where should I put the implant? Deeper?
Doctor, when we put the implant deeper, as I know, all this bone will be removed, right? It will be resorbed.
No.
And it will
No, this is
it will be
zero.
replaced by soft tissue, right?
No, no. If you do it this way, this bone will stay. This bone will not. See, the reason why we lose the bone is because we are disturbing the connective tissue. That's why, what was the first element of the rule?
But we said before, one second,
Platform switch.
but we said before that the bone will go down till the first thread or till the platform switch. It
Yeah,
will not stay up.
Yeah.
If we put the implant 3 millimeter below the bone will go till the first thread.
No, no, no. If you follow this, you can escape that normal theory. If you follow Thomas, you can escape the general rule. This is more advanced than the general rule. This is another theory on top of the general rule.
Then, okay, I'm with you. Now, if we have thin biotype, for example, we have 1 millimeter of
By the way,
soft
one
tissue.
more thing. The last part I said is, you remember we said this bone is too hard, we make it, we grind
Yes.
it. So when you do this,
It will allow soft tissue to go there, right?
not question of soft tissue, it's a connected. You are changing the position of the gum now. You're making your gum longer because you grind this.
Yes.
So you make the 2 millimeter, 3 millimeter. correct?
Yes.
So then, when it's
Now-
3, it's easier for you to plan your cuff height because it's no longer 2. Now you have 3 millimeter, 1.5 for the connective and 1.5 for the epithelium. Because
Okay.
you removed this part which was in your way.
Okay. Now, if I have 1 millimeter of soft tissue when I start,
There is nothing 1 millimeter. Nobody has 1 millimeter of soft tissue. You cannot have, according to
2 millimeter of soft tissue.
minimum 2 you
Okay.
have.
2 millimeter of soft tissue. We have thin biotype, 2 millimeter of soft tissue, or less than 2 millimeter of soft tissue. And then we have the bone, right? We have to go 2 millimeter below the bone.
Yes.
But now, if we, then this thin biotype will stay.
No. What did Ahmed say? He make it thick. He did roll, he did this, he did that, he took from palate, he did.
Okay, now if we want to make it thicker, okay, now it will be, then the thickness will increase to 6.
No, even if you give, if you come to a standard 3 to 4 millimeter, enough.
I think there is some misunderstanding.
Yes, explain.
The point, doctor, she's talking about when you put the implant in surgery day, if you put the implant 3 millimeter down, what will happen? She's talking about that stage.
3 millimeter below the bone.
Yes, below the bone. Now,
It will allow the soft tissue, after remodeling, this 3 millimeter will go to the platform switch, right? It will resorb.
let me finish I finish my sentence. Now, here we are talking about when restoration time,
Yes.
not surgery time.
No, but let me explain. Surgery time, when you are planning the surgery, minimum
5 millimeter.
4 is the minimum, 5 is the
millimeter.
maximum.
Yes.
So if your gum is here, you don't care where is the bone. Wherever is the bone,
Yeah, exactly.
you go 4 millimeter and you place your implant.
Exactly.
Let me finish.
Okay.
If your implant is above the bone, you put 4 millimeter, but your implant is above the bone. Should you go deeper or not? Should.
To make it
Because
5.
you, huh?
So that you will have the 5, right?
No,
Make it
so
5.
you have the platform switch working for you. Even half a millimeter below the bone level, what makes the platform switch work for you. So, we have given you some principles, but you also have to be awake to understand the entire. You just don't say every time 4 millimeter and that's it. What if the gum is 5 millimeter? You put 4 millimeter? 1 millimeter above the bone? No.
It becomes 5.5.
You put 5.5 and then your cuff height will be 2.5. Okay? And then you have enough room for your 3 millimeter of 1.5 for your zirconia and 1.5 for your epithelium. You're done. You understood? No?
Doctor, can
I think there is a problem in maybe understanding the zero resorption concept with the 5 millimeter. I'm getting the impression that people are thinking whatever depth you put your implant, you are going to have more resorption to the first thread, and that is not.
Okay. To find the only stress causing spot to stop the bone level by remodeling, which is the first thread. Those implants that cause bone loss to the first thread, for example the Straumann and all that, they did not have platform switch. So now we are talking a language which is 2023, 24, 25, these 2 years or 1.5 years, where we do not accept implants without platform switch. We do not accept the Straumann soft tissue level in this concept. They don't work unless you want to do overdenture or something. Yes, sorry. Go ahead.
Theory, when we follow Thomas' theory, we have bone growth.
Repeat your question.
Yeah. Now,
Only I want to bring Ahmed here.
yes. No, say that in the microphone.
opposite to old theory, when we follow Thomas' concept, we have bone grow, not bone lose.
Okay. What he is explaining is when this is concave, when this becomes concave, not straight or convex, the amount of thickness of the connective tissue here becomes more. Whenever there is a thick connective tissue, it signals to the osteoblast we need bone. So there will be new bone formation under this concave area. Where it will go here, under it. Thick connective tissue invites bone, creates bone, which is not there, but because we went deep. So this is a new philosophy that we are learning, that now let's forget losing bone. Let's create bone under my concave abutment. So this is because we know thick connective tissue invites bone formation, we are talking about this theory. The worst scenario in this theory, even if you don't create bone, you don't lose bone. He's not saying always he creates bone under his abutment, but he guarantees at least he will not lose bone. So he calls it zero bone loss theory. Yes.
Taking this theory, and I don't know if it's related, but how can we choose our healing abutment based on, like, usually they give us in the course something long or short. I don't know if it's related to this
No, it's
concept.
very related. Healing abutment or eye physio should not disturb the 1.5 millimeter. So if the healing starts becoming wide from here, do you think it's advisable or not advisable?
No.
Answer the question. No, forget eye physio. The healing that they give you. If it starts becoming big from implant, so when you have a healing in your hand, after today's lecture, you should make sure the first 1.5 millimeter is straight. If concave, but still the manufacturers have not reached to start making concave healing. They will very soon. I'm sure they will. Because now we are creating bone. We are not worried about the osseointegration. All that is over now. So the first 1.5 millimeter, if not concave, at least straight. Then wherever, depends on how deep you went. If you put the implant 0.5 millimeter below the bone and your straight part of the healing is around 2 or 1.5 and 2, then it starts fine, fantastic. Actually, I prefer if it becomes huge after the 2 millimeter or 1.5. Why? If it was an extraction socket, I want to preserve the shape. If it was a closed, no, I don't want it to go wide. Let it be as small as possible. But if it was an extraction socket, all this will collapse. There is no way you can get it back. No way. Unless you do a soft tissue grafting and then temporary healing and the temporary crown and then wait 6 months and then slowly make it bigger and bigger. Yes. Yes. He has the mic, so.
No, go ahead. Okay, no, the question now, just to give a point about that, if I have 2 millimeter soft tissue and they go 2 millimeter in the bone deep, I will not lose that 2 millimeter of bone. This is what Dr.
This is the
Shiwad.
basic.
Yes,
First sentence.
I go 3 millimeter in the bone, I will not lose this 3 millimeter.
Yes.
This is what we
Yeah,
now.
3, but then you go 4, you might lose 1. I mean,
Yes.
between 4 and 5, try to come up.
No, I don't mean we have to go very deep. Just I mean,
I'm
if
just-
I go deep,
No,
2
I'm just
millimeter.
telling you,
Yes.
look at the gum level. 4 is, between 4 and 5 is where you have to
Stop.
stop your implant.
So I not be worried that
Huh,
this
no.
bone I will lose. This
Yes,
is my point.
this is the
This
first.
is what Dr.
But,
was.
but don't forget the bone which is at the neck of the implant, which we were happy to go 45, should not be stretched and
Yeah, but
stressed.
sometime-
You have to remove that bone if it's tight, so it is barely touching the implant. That is one reason why again the bone will, because we go 45, the load is not the tip, the load is at the neck. Of course this will go away, and then you go to the first thread and you say, so see, I went for, I lost the bone.
No, this is because cortical bone. Now, if you have in the maxilla,
Huh? No, if you don't realize the stress of your 45 is coming from where? That's why before putting the implant, if you checked your Hounsfield unit, if the neck is high in number, you can make the hole, only the 1 millimeter neck, wider than the implant. So the neck is not what is giving you, is it false positive? I think it's called false positive. Or is it false negative? False positive. You know what's a false positive? You think the entire implant is 45, but only the neck is what is 45. The whole thing maybe is 10. So to not have false positive, you make sure if the neck is cortical, if it's extraction socket, nothing, don't do. But if it's cortical, you make the neck only 1 millimeter neck, wider. So when you are tightening and you get 45, you know it's not from the cortical bone, it's from the body, which is okay. Can you stress cancellous bone?
yes.
Yes. Can you get resorption by stressing cancellous bone? No. Can you get resorption by stressing cortical bone? Yes. See, this is the theory. Because if you stress cancelled bone, you don't get resorption, you get just remodeling in a very normal way. You want to stress cancellous bone. You don't want to stress which bone you don't even want to stress 1%.
D1 bone.
You had coffee or tea or water? Tea? I want some answer to just say I'm proud of, I'm still proud of it. Which bone you don't want to even stress 1%? Augmented bone. It's the worst bone.
Yes.
Augmented bone is dead bone. Even it was 6 months ago. If you stress it, of course it will. Maybe in cortical bone, Cancellous bone you can stress as much as you want. 45, fine. Cortical bone, no. Augmented bone is the worst bone you want to push because it is plastic, it's not elastic. So you'll either crack it or ruin it or make it worse, resorb, whatever.
So, augmented, which bone augmented? Yeah, I mean alloblast or allograft?
No,
because
Xeno.
Yes. So because this augmented bone, we cannot say, because alloblast, there is some kind of bone. It already after 6 months it's become natural bone.
Yeah, if it's natural, then it's
Yes.
cortical or cancellous. If it's cortical, don't. If it's
No,
cancellous,
usually it's cancellous.
okay. That's not augmented. I'm saying the remaining augmented. Still, it's
It's mean,
augmented.
yes, xenograft it is.
It's still augmented,
or blood.
but it's hard. Don't push it. It will
Yes.
not work. All right, let's come to this one. I like this photo a lot.
Yeah, because it's okay.
No, answer. I will answer if I.
Okay, I think I see a little bit of confusion even for me when we are talking about stresses. When we are doing an implant, let's say 1-2 millimeter below bone. You cover it with a screw,
Cover screw.
cover screw. Okay. Are there any stresses to this implant right now with the bone?
If it's 2 millimeter and you are in cancellous, no.
Okay, we are definitely in cancellous after 2 millimeters. I mean, yes, يعني most of the time. Okay, so there are no stresses. So the stresses that we are talking about is when you actually come and put when you load your prosthesis on it, then you're going to have stress, then you're going to have bone loss.
No,
at this
many
end.
times, because always this part is bigger than this part. Because all
Yes.
our implants are conical.
Yeah.
Yeah?
Yeah.
So this part, as it's going in, and you putting it 0.5 millimeter below, or some of you putting it at bone level, this part, because the way you drill is made, is not 100% the shape of the implant. They want you to have primary stability. They did not make this part in the drill like this. It's almost conical like the implant, but the neck, they don't have in the design of the drill cortical cancellous. You with me?
Yes.
So this is the part which is the key to the biological width, this 1 millimeter.
True.
Because if this goes down, the whole thing goes down. So to keep this guy in the same position, this 1.5 millimeter should not be disturbed. So
Yes.
our key is,
Which
if we disturb this gets disturbed, because this has to remodel. Osteoclast will come because there's stress. What is being clearly published is cortical pressure is the main reason why we lose the first thread after few months, 6 months, 5 months, 9 months. So that cortical bone should not be, if it's not stressed from inside, if you make it, you cut it, because it's hard, it doesn't resolve, it stays, because it's harder than everything else. So it can tolerate the biological remodeling, because it's a very hard bone, cortical bone. But from inside, when there is stress, it cannot take it. So that's why because it's thick, so it doesn't get quickly resorbed. The resorption comes, that's the same concept about making the wall of China, why it failed, because the problem was from the people inside, they took bribe. That's why the wall I did. So inside stress is cause of the damage, not the outside stress. I need to finish few photos, go ahead, but I want to go further, then we come to questions. Can I just go 10 slides? And then we, yeah? Okay, so the total contour angle, you can reach to just where you can see with your eyes where the gum ends, that's where you see. So here, it should be almost closing the contact, yeah? But how to get from here to here? Many labs, they start from here and they make a line. What we are teaching you, don't accept this kind of a crown. 1.5 straight, then go. If you are smart, 1.5 concave, and then you go. This is what we are teaching you today. Don't accept this straight line, which all the labs do for you, because it's quick, fast for them, easy. All right, so, yeah. Now, the last epithelial area, you can make as much as convergence that you want. Now, let us look at the clinical cases. This patient did this crown somewhere else. She did the implant with us. And of course, already the damage is done. So what I did, if there is a video, there should be a video. Let's go back. So what I did, I took a round burr and I make the 1.5 millimeter, no, depressed concave. So the connective tissue will travel inside my area, so it will help little bit the damaged one on the left. I cannot close that hole, but I can make the gum creep down by making my unglazed 1.5 millimeter, the first part, till the connective tissue concave. So this one is straight, coming out from here, I make it concave. Wherever it's concave, that means thicker, soft tissue. Whether it's epithelium or it's connective tissue, hopefully if it's epithelium, it will be glazed, and if it's connective tissue, it will be unglazed. All right? So, what are we talking about now? Imagine this is the implant. The first 1.5 millimeter is connective tissue. Then we have the junctional epithelium. Then we have the cervical epithelium. Right? So the first 1.5 is the part that should be concave as much as possible. The second half, you can start the emergence profile, and this is your last chance to make it look aesthetic. Your last, whatever is left, their area. Now I have very nice slides to make this more practical for you. Now, what is this? Now, to select the abutment cuff height, right, we are dependent on the implant depth. So if the implant is less deeper versus more deeper, depends on the bone, of course, not the gum. If the bone is here, for example, and the implant is here, of course we're going to rely on titanium. So the titanium, which is allowed to be inside the bone, will be the way we select our cuff height. Okay? Now once you cross 5 millimeter, then you are in trouble, because then what she says will happen. The bone will start finding another biologic width, because it's too deep for the body to be able to control the depth of the remodeling. So this is a 0.5 millimeter cuff height. That is, say, 2.5 millimeter cuff height. See, this one and that one. You understand the difference? So if you place the implant 0.5 millimeter below the bone, this is your best abutment if you did pay attention to the 4 millimeter of soft tissue. And once the zirconia starts here, till at least 1 to 1.5 millimeter, the zirconia will be straight and it will not be glazed. Then the epithelium will take over, the glaze will take over, and the emergence profile will start. Okay, so now I'm repeatedly putting this in relation to the abutment, so you can understand where is the abutment going to start in relation to the implant. So can you, Zainab, can you read this?
At least 3 millimeter zirconia subgingivally, 1.5 millimeter unglazed zirconia touching connective tissue, and 1.5 junctional epithelium, 1.5 millimeter glazed zirconia. So touching the glazed zirconia.
So is this slowly giving you a bigger picture now? So you want to create a 3 millimeter gingiva. If you have 2, try to make it 3. 3 will be easy to divide. 1.5 connective 1.5 for the second child. You know, you give the first child his thing, or the second wife, I don't know, whichever you want to choose. You give enough ammunition for this 1.5, different treatment, this one different treatment. You're asking.
Yeah, 3 millimeters zirconia subgingival, 1.5 angles zirconia touching connective tissue. From the 3 millimeter subgingival, what is circular depth, for example, in this example?
For example, you used a 0.5 millimeter abutment height, cuff height. So now this is exactly above the bone.
Yes.
So now you have 3 millimeter, 1.5 and 1.5.
So which one on the half?
Okay.
The one which is this one is glazed, this one is unglazed.
But now if you have sulcular area with the implant of 2 millimeters,
That's what we're trying to make it 3 by rolling, by whatever, by connective tissue, by 2 is not a good number to start with. That's why we have to go deeper.
Okay.
We don't want to go deeper. We want to create at least a 3 millimeter starting point. So when we are checking the implant, quickly we go to CBCT. Where is the bone? Okay, calm down. Where is the gum?
okay.
Can you make it 3 millimeter before you go to CBCT? Can you calm down, check? Maybe it's 2 millimeter. Can you make it 3 millimeter? Can you do connective tissue? Can you do roll technique? You understand? I'm not saying take it from the palate, maybe from distal, maybe. Start to create a 3 millimeter gingival height to be able to place your implant in an ideal position. Okay, so the part I'm trying to make it concave, okay, is the part I'm trying to make it thicker, to invite thicker connective tissue. So once I get something like this using iPhysio, the shape of my healing, which is called iPhysio here, is kind of close to the shape of the neck of the extracted tooth. So this way, I know that the 1.5 here is straight. It doesn't start from the base. They designed it thinking that 1.5 should be straight. So this one, the first 1.5 is not coming out. This is the implant. 1.5 is coming straight. From here, it starts to give you the 911. Okay. Alright, so now when I put, of course this is lick stop, it's not pus. When I put this in, slowly I can see the gum is coming downward because I made a concavity. So I'm helping this poor implant, which was done by somebody else, to actually not receive more bone loss by making my implant more concave instead of straight. So I'm helping a thicker connective tissue between them, so at least it will stay there and it will not continue resorbing because of Thomas zero bone loss theory. So I'm removing the pressure which was created by the previous dentist. Okay, this is the same thing but explained in only for Zainab. Nobody else can read this. Can you read this loud?
Counting subgingivally downwards, 1.5 millimeter subgingival glazed zirconia crown. Then below that, 1.5 millimeter subgingival unglazed zirconia crown. Then below that should be the margin of the abutment. Then below that should be the abutment cuff height. Then below that, the implant crest.
Alright, so now I'm showing you different cuff heights. Okay? Same implant. Alright? Now you can decide what abutment I should not use, what abutment I should use, cuff height wise. Right? So now Based on this, it's easier for you to decide what cuff height to use when you are going this way, and where the zirconia will start, how it will start, and which one is glazed, which one is unglazed, right? Is it easier now to understand? Alright, did we read this also?
Convex subgingival profile. This shape supports soft tissue volume more than or equal to 2 mm inside junctional epithelium. Concave subgingival profile. This shape supports soft tissue volume 1.5 mm inside connective tissue, maintains a thick phenotype. Number 3, platform switch abutment. 4, abutment cuff height from 0.5 to 3 mm. 5, implant diameter with 2 mm buccal bone.
Okay, this is the summary of the Thomas. In one, the only part missing here is the cutting of the hard cortical bone, so we don't push it if there is a hard bone. That part I have to add. It's called profiling the bone. Except that point, this kind of summarizes the theory.
Number 2 is concave or straight, right?
Concave
Or straight.
or straight. Concave is better, straight is okay. Better than convex. Today, most of the crowns we get from the lab is convex. It's not straight, it's not concave. Slowly, as we go, we more insist, return the crown, get back till the brain of the technicians also understand, and then slowly we get to this theory.
So doctor, we send to the lab the cuff height and how much we want unglazed and how much glazed. We write them in our...
Yeah, better, but once you send the cuff height correctly, and you tell them always 1.5 millimeter above the 1.5 millimeter of your zirconia should be unglazed, automatically it becomes correct.
Yeah, because they will not read the gum, they only have the bone and the implant.
Yes.
So we ask them to do cuff height by millimeter and how much we want
Or you can
unglazed.
draw. Don't make it emergence profile from the abutment level.
Yeah.
After 1.5, then you can draw for them.
Yeah.
Okay, this is the detail of what I told you. Okay, maybe we should read it because this is the detail of the
Subgingival implant depth 4 mm below gingiva. Recommends placing implants 4 mm below the gingival margin to preserve soft tissue architecture, enhance aesthetics, and stabilize the bone implant interface by maintaining the biological width enforced genetically. Platform switched abutments. Utilizes platform switched abutments narrower than the implant diameter to reduce crestal bone stress, minimize microgap related inflammation, and redirect forces inward, preventing peri-implant bone resorption. Biomechanical optimization with concave abutment design. Designs prosthetic components with a 1.5 mm supra-implant unglazed zirconia abutment featuring a concave subgingival profile. This shape supports soft tissue volume more than or equal to 2 mm, encourages natural gingival contouring, and maintains a thick phenotype evenly to promote maximum blood flow and lymphatic drainage. Socket preservation and immediate placement. Combines immediate implant placement post-extraction with socket grafting, autografts or allografts to maintain alveolar ridge volume and prevent collapse, ensuring adequate bone for stable long-term implant integration with crestal bone shaping final drill.
You get it? Shaping? The only thing is, when I told him I do this with alloplast, he was not happy with alloplast because his theory, I took this from his book, but we added alloplast here. This one we added, and one thing we added here was, what did we add here? Something we added here, I'll remember, but this one, of course, we added alloplast to his formula. Continue.
Minimally bacterial invasive protocols with internal cone connection employs minimum microleakage during loading to preserve bone integrity and shielding it from microbial and mechanical disruptions to optimize bone metabolism and healing, ensuring zero bone loss outcome.
Now, this is very, very serious. Why? Because when you buy the abutment from the manufacturer and they are not internal hex, they are not external hex, they are internal cone, they assume that the minimum amount of bacteria is going inside the implant. Okay? So when you make a full mouth, you cannot get that perfect fit because it will be non-hex engaging and it will be just fitting. So to make the story short, don't expect zero bone loss with full mouth. Plain, I'm telling you. Because you will not use internal cone for full mouth. Where is internal cone? There should be some internal cone.
With internal core.
Internal cone. Because they have to use non-engaging abutments, multi-unit, right? So if they use multi-unit, it's fine. You will do fine. But if you decide to go UCLA, you will not have internal cone. You will have a round going inside the implant, which is never internal cone. So one more way to have Thomas theory is to use multi-unit abutments. So multi-unit abutments preserves the bone better than going UCLA. Multi-unit abutments will preserve the bone better than going inside the implant. The case you showed me, it had multi-unit. That one is better for full mouth, for keeping all the bone level, because when it goes in for full mouth, it cannot be internal cone. When you put multi-unit, each multi-unit is internal cone. So you close the hole with an internal cone. Then you put the prosthesis on top at the gum level. You are not disturbing the 1.5 millimeter of, because that's already sealed with your multi-unit. You understand? That's very important. Many people go to implant level, full mouth. You disturb this 1.5 because your prosthesis will go all the way to the implant, right? Yes. You cannot seal it because it's round. It's not inside the cone. So there will be leakage. And when you remove it every year, you can smell and you can see the calculus.
Regarding number 4, can we preserve the socket with the custom-made abutment?
Better, even better.
Without bone graft? And say we will not put bone graft and just we apply the custom-made abutment?
If the hole is big, the epithelium will creep in and destroy you. If it's small, maybe. But if you put bone graft, according to Thomas, it's safer because you stop the creeping of the epithelium in the cavity. So better to put something.
Since we're not removing the multi-unit abutment at any stage later on after the surgery, do we need to use a leak stop at the time of the surgery?
No.
So leak stops not needed.
The 1.5 millimeter supra-implant unglazed zirconia abutment ensures the portion contacting genetically determined connective tissue 1.5 millimeter remains unglazed for biocompatibility and soft tissue adhesion, while the supragingival segment is glazed to resist calculus, and the sub-bony abutment cuff, titanium or non-ceramic, avoid
The titanium, which is we are
Okay.
requesting you not to use zirconia in the bone,
Okay.
because zirconia is good for the soft tissue
tissue.
adhesion. It's not
For bone.
for bone.
Avoids bone adherence, optimizing peri-implant stability and minimizing bone loss.
Thank you. Now, just to finalize quickly, so for the straight multi-unit, you have different cuff heights. You can select them according to what we discussed. You can use all this is the parts that you need. You have a multi-unit, which you tighten with the screw, and then the abutment, which will be tightened with a smaller screw. This is the big screw which goes here, and there is a tiny screw which goes here and connects the prosthesis to the multi-unit. So the more the angle, the longer the cuff height. You cannot get a 30-degree angle multi-unit with 0.5 millimeter cuff height. Doesn't exist. They don't make it, right? So the more the angle, the longer the cuff height. And if you place, for example, a 30-degree multi-unit abutment, and you put the implant at 40-degree, right? Or even, I'll make it even worse, 50-degree implant. You put it like this, and you put a 30-degree angulated abutment, right? And still it looks ugly. You can use a dynamic screw for the multi-unit. It gives you another 15-degree forgiveness. So even that you can do. But you need to use a multi-unit to start with, because you break 30 and then it gives you bonus. But if you start to the implant, 28 degrees is the maximum you can get out of the dynamic. Thank you. So the dynamic can give you up to 28-degree correction. So this screw comes here also. So you can get another 15-degree from the second time. Now if you use, say, non-platform switch, then you have to use the laser neck, the only implant which supports the soft tissue attached to it creates a rough surface for the hemidesmosomal attachment, for the connective tissue, to adhere to this part. Otherwise, the bone will go to the first thread. Alright, now when you start selecting the abutment, this is the implant, external hex, this is internal hex, this is internal cone, and this is internal parallel, which there is, I have another study to show you what is the difference between these two, but nowadays half of the implant is internal cone and this part is straight. This designs, mixture of these two, is the best design. The upper part is concave, it's angled, and this part is straight. This causes less stress to the, why? Because of the wall.
No breakage.
Yeah, this is weak. This is strong. So people realized this is safer. Because if this goes 0.5 millimeter deeper, the stress here is twice than the straight line.
But there is, who's the system using this? I know one system, but I will not say the name.
I will show you later. I don't think today we have time for going to this formula, but I did a study on this, so I know a little more about this design.
We need this next time.
Hopefully. Alright, so now the question is, you look at this panoramic X-ray. you should select the abutment now. From now on, the abutment gets decided from even the panoramic, right? So when you look at any scenario, you look at the patient's mouth, now you should select the abutment. Because based on the abutment, you can select the 1.5 millimeter undisturbed. So now you think, oh my God, even when I look at the teeth, I can visualize that 1.5 undisturbed, so I can decide abutment, whether it's multi-unit, whether it's deep, cuff height, all that. So I'm taking your vision or your insight, where is insight? Yeah. I'm taking your insight to that 1.5 anytime you look at the patient, whether it's panoramic. For example, let's go to this panoramic. Now I'm thinking the 1.5 above this line, this is bone, right? Should not be disturbed. I'm looking at this, I'm seeing the 1.5 millimeter I apologize. The 1.5 millimeter, if this is very thin, you see it could be 2 millimeter. Here it could be 3, here it could be less, whatever. I'm paying attention now to that 1.5 above the bone. So I'm giving you another insight that you never used to pay attention before today. Same thing here. I normally open my CBCT for implant selection, diameter and length. I'm giving you, look at the 1.5 above that. Select the abutment now at the time of CBCT. Before you place the implant, select your abutment, because that abutment is preserving your 1.5. Your implant is not preserving your 1.5 or respecting your 1.5. Your implant is in the bone, it doesn't respect anything, just it has to be inside. We used to pay too much attention to the implant position before the zero bone loss theory. Now the implant position is actually related to the abutment position, which is more important than the implant position. So when you look at this, I know you mentally want to select the implant. Correct, I don't have a problem with that. I have a problem with selecting the implant but not selecting the abutment, which is respecting the 1.5. Yes?
Can we get the implant depth, not position?
Can you know the implant depth?
Yeah.
The implant depth up to abutment, not the implant position. Implant position has to be up to the crown.
Okay.
The implant depth has to be up to abutment.
Yes.
Not position.
Yes.
No, not
is
more
it a question
specific.
or it's a point?
Question.
Repeat then. Sorry, I missed that question.
You said the implant position has to be up to the abutment. I want to replace position by depth.
Yes. Okay.
Only
Yes.
depth, because
Fine.
position has to follow crown.
Yes. Correct. You are correct. Then my only issue is when you are, yesterday when you look at this, you are selecting the diameter and the length of the implant. From today, 8 p.m., Wednesday, what is the date? So it's registered? 23 April 2025. When you see this and you put your implant, don't finalize the position of your implant till you think of the 1.5 and where will the, or how, or whatever the correct grammar, the abutment will be in relation to the implant. And then you respect the 1.5 and then you think of the final crown, and then that's the best place for your implant. So when you are torquing the implant, you are thinking the 1.5 and you are putting your implant. Can I preserve that? How you want to preserve that? You need an abutment. So you're thinking of the shape of the abutment where it will be. So my first zirconia will be touching the connective tissue without pushing it. All that comes at this stage. So when you open a flap, you can see the connective tissue. How you see the connective tissue? With a ruler. The first 1.5 is the connective tissue. You cannot see the cells, but you can see the distance. And then you can visualize how the ceramic is going to start at there, and then accordingly you go deeper or not go deeper. That's my point.
So doctor, this means if we have two implants parallel to each other, they don't have to be same height. If the connective tissue is different.
Or you create the other one to match this connective tissue. You make the connective tissue equal, so you put the same. Even this case, she comes to you and she wants a single implant. One way is to look at her and say, I can give you an implant. You look healthy, young. The other way is where the abutment will keep the soft tissue in place in this case. This is it. How you look at her is you look at her abutment, because that's what keeps the... This patient is an IDSC full mouth from Montreal. He came all the way, he stayed in a hotel. We did full upper, full lower. I went and saw him last month. I was in his house having kebab, and he was talking. I just recorded his talk as he was telling us stories. I noticed, because when I saw him here without teeth, we extracted all, it was all treated. I noticed, I want to repeat the video. I want you to, what time is it? The prostate? Oh. Just tell me what things you see here that, huh? So he has two things. One, when he talks, the right lips go higher than the left lip. The second thing, every 2 sentences, he has a very strange way of twitch on the upper right lip. Yeah? So when I look at my aesthetic concerns, and I don't take a video of the patient talking at the time of diagnosis, sometimes I might miss something which is... So that's why, for example, in this case, we made FP3, which means a curtain, pink curtain. So he does whatever he does, it will be covered. I'm safe. But if he's going to do that, and this gum is higher than this gum, in your case, because we want to give him not curtain, then in this case he will look ugly. Because every time he does that, we're going to see the gum, which is not the same level as this side. So it will be different. So if it's 8 o'clock, I think we should stop. The easiest way to choose a cuff height is this. Now, let's see if I have another color. Let's talk about the facts. We are 100% sure. The facts are, you don't want zirconia to go to the bone. Agree? Okay. So, the abutments they sell, most of the companies, 0.5 millimeter, 1.5, 2.5, 3.5. Anyway, you don't want to go more than 3, right? So you have 4 choices. Easier than 5 million choices, right? Imagine you have 0.15, 0.35, 0.65. So you have 4 choices. Okay, so this is 2 millimeter below the bone. Okay, you want to be 0.5 millimeter above the bone to start the platform. Here, the first 1.5 millimeter will be unglazed, then the other 1.5 will be glazed and starting to come out, and the last part will really come out, which is 0.5 millimeter, till hopefully the eye can see from here if this is 3 millimeter. Sorry, this cannot be half. So it's 1.5, 1.5. If this is 3.5, it's ideal. This part is the real, the last part. If not, 3 depends on the, how high was your gum?
2 million.
Real. 3 is normal. So, what do you think if I want my platform to start here, and this is 2 millimeter below? خلاص. You got the message.